We're going to begin with the chest exam now, and there's many parts that overlap with other areas of the body. We're going to concentrate on the ones that are more respiratory system or the areas right adjacent to that. First, I look at the patient, and what I want to know is how are they breathing? Are they in distress or working hard to breathe? What muscles are they using that might be accessory muscles of breathing? Counting the respiratory rate, as soon as you tell them you're going to do that, will get you a different number. So you have to be cautious. Often the nurse has already taken that. Be suspicious if you get a number of 20. Not many people really breathe at 20. I suspect that the average is around 14 or 15. And most of the nurses will multiply by 4 after counting for 15 seconds. So you'll typically see either 12 or 16 or 20. I actually usually look at the hands first. What I'm looking for is clubbing. Clubbing is actually an elevation of the back of the nail here, and if you're not certain and you think it might be curving of the nails rather than clubbing, if you put your fingers together like this, you should be able to see an airspace. You want to try that? In normals, there's an airspace at the back of the nail there when you put them together. If the clubbing is present, it raises the back of the nail, and that space, that airspace there you see, is obliterated. So there's no lifting of the back of the nail that goes along with clubbing. It is associated with some interstitial lung diseases and other diseases of the lung, as well as other things. I then concentrate on the neck, and what I'm looking at are the muscles on the side that might be used as supplemental respiratory muscles. The scalenes are in this pocket right behind the trapezius, and those are probably the most sensitive. Those are recruited early in breathing. And in fact, if you run, they're recruited for use. Later on, the trapezius in the back and the sternocleidomastoid are recruited, and those are much more obvious. In children in particular, you may see retractions between the ribs that indicate that they're really sucking in hard, and that's transmitted to the outside. That's rare to see in adults. I then examine the neck for lymph nodes, and I think you've already covered that, or will in a future segment, and essentially the anterior and posterior chains of the neck, and then the supraclavicular nodes right behind the clavicle. I then note the trachea. The trachea is in the center. It should be in the center. If it isn't, there's a reason. I use one finger and palpate each side, and it should feel the same. If you use two fingers, you get a different sense from each side. You also want to note that if it's descending or moving abnormally, that's a sign of respiratory distress. The sternal notch is here. A little further down is the joint between the manubrium, it's the angle of Louis, and that's the second rib anteriorly, which is a good landmark to judge where you are in the anterior chest. She's not in any respiratory distress. Inspection-wise, you also want to comment on the anterior-posterior diameter. I find it easier to do that from the back. So let's have you turn around, and we'll start from the back. First, the obvious thing is the spine. Is it straight? Is it curved? Is it curved to the side or too straight? Kyphosis for a curve forward. Lordosis for an abnormal straightening, and scoliosis for a curve to the side. Another trick for the scoliosis is you may not see it obviously, but if you bend forward a little bit, there's a pretty straight there. Or you see one shoulder slightly raised up, that's often a sign that there may be a subtle curvature that you might not notice otherwise. In terms of judging the size, obviously there's a ratio between the side to side and the front to back, and if that's increased, it's called a barrel chest. There is a little bit of change with age that also occurs. It's better seen actually on chest x-rays than anything else. In terms of excursion, you want to see how much they expand the rib cage. And if you put your hands on the side and get your thumbs reasonably close together, when you take a deep breath, you'll see that they move apart. And if you do enough, you can exhale. And if you do enough, you'll get a sense of sort of what's normal. You can do that same maneuver on the upper chest in the front to get a sense that the upper ribs are expanding the chest cage. And in patients with emphysema, because the insertion of the diaphragm is flatter, it may actually pull in at the bottom when they take a breath in. After you've inspected the back, I usually go ahead and do the percussion auscultation on the back and then move to the front as necessary for more inspection and percussion. In terms of percussion, it is a difficult thing to learn. You have to practice, and I use the sort of indirect method where you tap on the finger. You're aiming for the joint here. You can't do it over areas that are very bony, like the scapula, but essentially your nice loose wrist movement. And there's a sound associated with it and a feel in your fingers, and both are sort of important. This, of course, sounds normal. It might sound overly hollow or tympanetic or dull. Dull areas might be effusions or consolidation from pneumonia. Depending upon why you're doing the exam, you might want to do that over the whole chest or a very limited area. Listening with the stethoscope, I think it's important to recognize that the lungs aren't just this small area back here, and that in fact you need to listen to multiple areas to get a sense of the whole lung. Most often you use the diaphragm, and you've already had the cardiac exam, so you know some of the bits about the stethoscope. When you listen, you want to keep it fairly tightly pressed against the skin, but not ground down into their skin. I'm going to take a listen, and what I want you to do is breathe with your mouth open, sort of medium-sized breaths, not overly deep. You want to listen to both the inspiratory and the expiratory sounds. And I generally listen to about 6 places on the back, trying to avoid, again, the scapula. Then I move around to the side. On this side, of course, the lingula, and over here, more the right middle lobe. The lower lobe is mostly what you're hearing on the back. When you move around the front, you'll hear the upper lobes and the middle lobe and the lingula. And if you hear abnormal sounds, you may want to listen to more than one breath. A couple of cycles of breathing may help you distinguish when the abnormal sounds occur. I keep it simple and divide it into 3 things: crackles, wheezes, and gurgles. And those translate into ralls and rhonchi, etc. Crackles are short, discontinuous sounds. They are associated with either scarring-type diseases or fluid filling the probably smallest airways. And then gurgles are larger airways that are filled with secretions, and think of it as bubbling through a liquid. And then wheezes are musical sounds. They're much longer. Sometimes they're very musical. Sometimes they're almost hollow sounding. All those things you can describe when they occur in the respiratory cycle, either inspiratory or expiratory. I'm going to turn around again to this side. We listen to the front. Again, you're listening the same in the same way. As you get over the heart, you have to ignore the heart sounds, and that's very hard at the beginning. But after a while, you can block out the sounds of the heart and hear the breath sounds next to it. The other thing to listen in the front is to listen to the trachea or the upper airway. You listen sort of on the side of the trachea, and I want you to open your mouth and take a breath in and out. And here you might hear stridor or narrowing at the vocal cords, either from vocal cord pathology or tumors or other things. Other sounds you might hear are real close to the ear crunching sound that may be air under the skin, and you can actually feel that when you put your hand on the skin. It's subcutaneous emphysema. That occurs mostly in the ICU setting and in patients on ventilators. If the patient has a pneumonia or other consolidating process, you may hear the abnormal lung sounds like crackles, but you may be able to bring abnormal sounds out by doing certain maneuvers. So when you listen, I'm going to have you say E, okay? And if it's an area of consolidation, it sounds like A. And it's very striking. Let's just do it once here. I want you to say nice long E. Okay, great. Now, normally what you hear is an E if the lung is normal underneath. If it's consolidated or filled with fluid, the high sounds are transmitted better and it sounds like an A. You can mimic that in a thin person by listening over the scapula. It transmits the same sorts of high frequencies. Other things that might bring out consolidation are whispered pectoriloquy, which you listen and you say a whispered thing. Usually we have people count 1, 2, 3, or 99s, and those can be louder voice, soft-spoken voice. And what happens is if it's consolidated, it's transmitted much better, and you hear the sound louder and more distinctly. The trick is, of course, to learn what's normal and do it in a few people that are normal, so you hear that sound sort of muffled. Likewise, when you have consolidation and you're looking to hear or find evidence of that, you can do the transmission of the vibration, and you put your hand, and you're primarily feeling with the palm of your hand, and if you say 99,
99, 99.
You'll always feel a little bit of vibration, but it's much more prominent if there's consolidation in the lung. The vibrations are transmitted much better. I think that concludes the respiratory exam. I've tried to focus on the parts that are specific for the respiratory system. Obviously, the heart and nasal passages and mouth are important to the respiratory system, and that exam would be included in most physical exams related to pulmonary complaints. Thank you very much.